Imagine inventing a life-saving heart drug, but the exact mechanism that saves the organ accidentally triggers a dangerous spike in a really harmful chemical.
Yeah, and you're suddenly forced to pair it with a second drug just to, you know, neutralize the fallout from the first one.
Right. I mean, it completely flips the traditional script of pharmacology. Welcome to today's deep dive. We are taking that stack of sources you sent over, specifically this dense Stat Pearls medical guide on the drug Sacubitril-Valsartan, and extracting the core insights.
Which I know sounds like standard textbook reading.
It does, but it's actually a brilliant story about how we fundamentally rewrote the rules of treating heart failure.
Absolutely. And to see why this is such a breakthrough, we have to look at how it manipulates the body's natural push and pull biological systems. Because during heart failure, the body basically panics.
Yeah, it activates the RAAS system.
Right, which causes harmful blood vessel constriction. But simultaneously, it releases these natriuretic peptides to try and flush out the excess fluid.
Okay, so let's unpack this. If you think about heart failure like a massive flood, you need two strategies here. It's kind of a good cop, bad cop routine.
I like that analogy.
Yeah, so sacubitril opens the drain. It boosts those good natriuretic peptides to help the body get rid of the fluid. Meanwhile, valsartan is like reinforcing the dam walls by blocking the RAS system to stop the vessels from clamping down.
Exactly. But here is the big aha moment in your source material. Why do they absolutely have to be combined in a single pill?
Right, because they're always prescribed together.
Yeah. Sacubitril works by inhibiting an enzyme called neprilysin. And neprilysin naturally breaks down those helpful peptides, so blocking it keeps the drain open, like you said.
Right.
However, neprilysin also breaks down angiotensin II, which is the exact chemical causing that bad vessel constriction.
Oh, wow. So if you use sacubitril alone, the angiotensin II just builds up to critically dangerous levels.
Precisely. You mechanically create a secondary crisis.
So you absolutely need valsartan there to block the receptors from all that excess angiotensin you just accidentally accumulated.
Exactly. And because altering that enzyme breakdown is such a drastic biochemical shift, it creates some really high-stakes hurdles for doctors.
Like what?
Well, for example, there is a strict 36-hour washout period required if you're switching a patient from an older class of drugs called ACE inhibitors.
Wait, 36 hours?
Yeah, a full day and a half. Because neprilysin inhibition also causes bradykinin to build up. So overlapping these drugs triggers a severe, potentially life-threatening risk of angioedema.
Wait, hang on. Stopping a severe heart failure patient's medication for a day and a half just to switch them over? I mean, I have to challenge that. Taking away their safety net for 36 hours sounds incredibly risky.
It sounds totally counterintuitive, right?
Yeah.
It is a calculated risk, but the alternative is actually worse.
Yeah.
The overlapping bradykinin buildup can compromise the airway entirely. Doctors really have to weigh that immediate threat of angioedema against a temporary gap in heart failure coverage.
Wow, okay.
And the complexities don't even stop there. The drug also creates a diagnostic hurdle called the BNP trap.
The BNP trap.
Right.
Because normally doctors measure a biomarker called BNP in the blood to see if heart failure and worsening, right?
Right.
But if this drug intentionally messes with natural protein levels and stops the breakdown of those peptides, your BNP levels are just going to look artificially high.
Exactly. Standard BNP blood tests suddenly become completely useless.
So how do doctors even track if the patient's heart is improving?
They have to change how they measure success. They have to specifically test for NT-proBNP instead.
NT-proBNP.
Yeah, it's a different marker entirely that is unaffected by the drug.
That is wild. And, you know, this hyper-specific way the drug alters fluid dynamics and pressure, it actually explains a lot about how different demographics respond to it.
Right, the anatomical quirks.
Yeah, like women respond favorably to this drug at a higher ejection fraction, around like 55 to 60% compared to men. And the reason why just comes down to anatomy.
Right, because women naturally have smaller left ventricular chamber sizes.
Exactly. So a normal ejection fraction percentage actually represents a smaller absolute volume of blood being pumped. And since sacubitril-valsartan is so effective at lowering pressure and managing that fluid volume, it uniquely benefits that specific anatomical difference.
It's incredibly precise, and yet it's surprisingly versatile, too. I mean, it's even approved for children as young as 1 year old.
1 year old, wow.
Yeah, they use a sprinkle formulation that they can just mix into soft food.
That's amazing.
It is. But looking at the literature, its off-label promise for chemotherapy-induced cardiac failure is really compelling to me.
Oh, right, because drugs like anthracyclines cause toxic oxidative stress, right?
Yeah.
which literally remodels the heart tissue.
Exactly. And sacubitril-valsartan actually acts as a shield against that structural remodeling.
So bringing this all together for you listening, sacubitril-valsartan is really a masterclass in targeted medicine. I mean, it proves that treating a complex disease isn't just about blocking a symptom.
Right. It's about meticulously managing these biological trade-offs.
Exactly. And, if this combination is already successfully mitigating the severe heart toxicity caused by anthracycline chemotherapy,
Yeah.
well, it raises a massive question for the future. Imagine this. Could we eventually see aggressive oncology drugs paired with advanced heart failure medications right from day one?
Like protecting the heart before it even has a chance to fail.
Exactly. It really makes you wonder what other delicate balances we can strike in medicine when we start looking at the body as a fully connected system,
Yeah.
Something to think about.